Hello everyone, welcome back to the sixth episode. So this episode I'm going to talk about diagnosis of the colic, and the idea of the detail in my presentation is based on the real case observation in elephants. So most of the practitioner will recognize the sign of the colic by the general clinical sign, but I'll talk a little bit on the detail, just kind of like shake the brain up a little bit and remember the old knowledge. So we all start from the basic. The first one is the history taking is very highly diagnostic value in this species. So most of the cases help identify the primary causes. For example, ingest of the poison or specific substances, uh, history of the last poop, time and characteristic. If it's dry, usually indicate impaction or constipation. If it's wet and watery, usually indicates spasm, infection or irritation of the bowel. If it's normal, could be something else, or strangulation, obstruction. If it doesn't produce the poop at all, so there should be the obstruction between the large and small colon. And if its amount of the production is reduced over the few days, the location of the lesion should be anterior to cecum. The degree of the abdominal discomfort also help predicting the severity. So if the discomfort is very severe, so the pain might originating from stomach or the extreme distension of the intestinal loop. And if it's mild pain, could be intestine. So for the brief physical, we can do heart rate or pulse depending on your preference. I prefer to try to auscultate the heart if it's possible, but it seems like most of the practitioners do not believe that you can listen to the heart rate by stethoscope. I think you should try, just break, kind of break through yourself. Respiratory rate usually increasing, and the degree of tachypnea and tachycardia help predicting the severity of the pain. The higher the rate, the more pain. Open mouth breathing is a bad sign because the elephant can't breathe, cannot move the chest. Mucous membrane color and CRT also important because it help indicating whether are there any cyanotic or any indicative of the endotoxemic sign. The temperature usually vary, but either increase or decrease usually indicate infection or endotoxemic. Gut sound and abdominal percussion is also important. I think you have to do it now. Even in the past, you kind of like declined to do it. So for the gut sound, I listen to four location, the left and right. The higher location is located between the last rib and the tubercoxa, we call palalumbar fossa, and the second location is on the ventral side and also on the other side, so totally four quadrant. If it increase peristalsis or sound, it's indicative of inflammation, infection, or irritation. Usually come with the clinical sign of the loose stool. If it decrease, in our case that come to me, usually it's decreased. It's indicative of distension, poor perfusion, drug, decreased GI movement, for example, like a spasmolytic drug, or also could be caused by pain. Remember, pain activates sympathetic, and the sympathetic counteract parasympathetic. Regarding with the percussion, you can percuss with your finger. If the ping sound present, it's usually indicative of the distension of the intestine, and that's the indicative of the tympany. If it's solid sound, it's indicative of water or fecal mass. And sometimes, percussion with stethoscope, it also help decide where to perform the enterosynthesis in case you don't have the ultrasonography. So the additional diagnostic tests may including the rectal palpation. This may provide very little direct diagnostic value because I don't think we can reach certain part of the intestine, but may provide the indirect clue what the problems could be. For example, if you get the feces that very dry, there might be the constipation or obstruction, or you might be able to palpate the distended intestinal loop, or you might be able to feel the gritty of the sand, something like that. The transabdominal ultrasonography is different from the other species, but help you identify the fluid, especially when you want to perform the abdominal synthesis. I think you should perform the ultrasonography first, and you might see the distant loop and the intraluminal content, and it is a useful tool to determine the integrity of the peritoneum and detect the presence of the peritonitis. In my experience, I have one case of peritonitis, but I was very little experienced. That's why I cannot identify it, because we don't know how to read the imaging, the image that we got it. But once it's a dye necropsy, then we know what we saw. So to perform the ultrasonography transabdomen, you need the convex probe. Less than 5 megahertz is the best. Scrub with the soap to remove all the fat, and degrease with alcohol and keep the skin wet. And regular ultrasonography, the ultrasound cooling gel will work. The key is try to keep the skin wet all the time. So the abdomen synthesis, Dr. Ratapan asked me to talk about this. It should be predetermined by ultrasound, that you use ultrasound and you see the fluid, then you can do it. In equine, we do midline, went to midline, but in elephant, I think you should do paramedian with 20 to 30 centimeter cannula. Endoscopy also very useful through the oral cavity, help you identify some teeth problem or the ulceration in the oral cavity. And for the esophagus, help identify choke and esophagitis. Choke you can identify from the clinical presentation, but esophagitis you cannot. The elephant with the esophagitis usually show the sign of difficulty of swallowing or don't want to swallow. For the stomach, help you identify the hemorrhagic gastritis. For the rectums, usually help determine the distance where the non-strangulation obstruction is located, but it doesn't have any diagnostic value, because you already diagnosed that the elephant have the obstruction of the intestine. For the abdominal tab, I've done a couple of them. So this one is the elephant with the, I think it's ectopic pregnancy. We removed the fluid before the elephant dead by cannula. And this is the endoscopy of the esophageal obstruction, one of the case. So the mass is about, the diameter is about 12 centimeters. So that's why we kind of know that the esophagus is expandable, but it has the bottleneck at the thoracic inlet. So the mass that bigger than 12 to 15 cannot be passed through the thoracic inlet. And in this image, you can see the necrotic around the mucosa of the esophagus. All right, that's it, and hope you enjoy it for the colic diagnosis.